Hello, everyone. Welcome back to the rpe.podcast, where we aim to bridge the gap between rehab and performance. I'm your host, Connor, and today we're going to be continuing our bone loading series, talking about bone stress injuries and stress fractures. Today, I am joined, as usual, by co-host Steve. How are you, mate?
Yeah, good, mate. I'm got some cocomelon on in the background, which is nice, and my daughter Mia here. So this will be her first podcast appearance. Yeah, say hi, Mia.
Perfect.
No, you're not
Uh,
getting a hi.
Perfect. Bit of extra diversity. Aim for the children. There's a thing on YouTube whenever I upload it, it says, "Is this for kids?" So maybe this is the first episode that's for kids. But today we're lucky to be
Love
joined
it.
by a podcast aficionado, very experienced podcaster, and that is Blake Withers. So if you've not heard of Blake, he's a sports podiatrist based out of Newcastle. He's also researcher academic at the University of Newcastle and very successful podcast host. Great source of reliable information. So definitely we will plug his Instagram and his blog, his website, and the podcast today. So thanks for coming on, Blake.
Mate, thank you so much for having me, and thank you for those kind words. It's awesome. Someone told me the other day that I am basically a content creator, so I'm trying to make better after that.
Okay, I didn't include that in the description, but content creator as well.
Yeah,
So
I don't know what's better, working at the uni or being a content creator. Because every time I think that, I think, far out, you're going to classify me in with that bunch? Because there's some absolute losers that are doing that.
You look like a real influencer to me, mate. I could see you up on the OnlyFans, I reckon.
That'd be all right. Maybe maybe a little 10% off discount if you mention this podcast.
yeah. So if listeners haven't heard about you, yeah, would you like to kind of introduce yourself a little bit further if I missed anything? Yeah, what's your story?
Yeah, so you pretty much got it all in there. I do wear a few different hats. I basically split my time half teaching at the University of Newcastle and lecturing in biomechanics, teach about foot orthoses in the sports podiatry curriculum as well, and tendons and muscles and loading principles for the kind of the hip down. And then the other days of my week is spent at a clinic with another podiatrist and a bunch of sports doctors and sports physicians, and we just see lots and lots of musculoskeletal complaints, lots of things below knee. Work with a bunch of physios and other health professionals within our local area, but we're predominantly musculoskeletal, so probably around 95, 96% MSK, which is really fun. We've got a big, beautiful gym, and we've got access to lots of different equipment and imaging and things, which is really cool. And then outside of my standard 40 hours, you would say, for work, I've got the podcast, do a bit of research as well, and hoping to do some further research and hopefully a PhD in the coming years on the topic of bone stress injuries, but just trying to sort it out and things, which is taking a bit more time than I expected.
Awesome, mate. Sounds super busy, but yeah, hopefully it's rewarding for you. Yeah, perfect guest to come on and talk about bone stress injuries. So super lucky there. Thanks, mate. We
Yeah.
do have, before we
What's
jump
I was
in,
going to go in there with.
go on.
I was going to ask a little question there, actually. Like, where's the interest in bone stuff come from?
Yeah, good question. I like, I really, I guess that the premise is I really enjoy learning about the human body. I just find it so fascinating that all these things and processes that are happening, and for us to understand it, how we can manipulate the things that we say and do to be able to change things in the body. So that's kind of the idea of just finding the body really interesting, and half the idea with the podcast. But for some reason, bones just make so much sense to me. Like, it's just, you can calculate bending forces, you can calculate the moment of inertia, whereas you start talking about tendons and it's like, oh, it doesn't really matter here, and there's nociception, and it just gets a little bit murky over in this side, whereas bones just, like, if you're an engineer, you'd probably be pretty good at understanding how bones work. Like, you can understand the compressive forces, tensile forces, whereas tendons are not so much. So it makes a lot of sense to me. So I think that's why I enjoy it.
Nice, getting that engineering brain kind of all sorted.
Yeah, and I think the idea of making bones like stronger seems to be a bit easier in the sense of, and this is hopefully what some of the research is going to look at, if we can maybe look to reduce some of the bone stress injuries that happen generally by making bones stronger. Whereas with tendons, we don't really seem to do that. Like you can follow a good tendon protocol, and we can't say it reduces your risk of injury, but for bones, we can make them bigger and stronger, which definitely reduces their, I guess, their failure rate. But yeah, we'll see how we go.
That's actually something we're going to be covering soon. And Connor and I were talking about that with tendons, how like it's so variable. Like, you know, you can look and someone could do like 400 jumps and be completely fine, and someone else do like 20-second isometrics and get the same adaptations. It's pretty
It's
wild.
weird.
So
Yeah. It's like, no, it's too much for me. It's too much for me.
Yeah. No, so far there's been the studies on bone stuff has been a little bit like mainly based in animals, like birds and chickens and stuff. So it'd be awesome if you can expand our depth of knowledge into actually what happens with humans.
Yeah, mate. I tell you what, every time I read a study, the poor rats, they've thrown rats and they're loaded like, yeah, we dropped this rat 60 times to test the rate of bone formation. I'm like, these poor rats just competent day in, day out to test the loading cycle stuff. Yeah.
Mate, isn't that one of the old ancient Greek philosophers? Didn't he say all a man is a chicken with no feathers or something on it? It was like Diogenes or one of those guys.
Yeah, like if you could tell the ethics people that, we'd be able to do a lot more in the bone research world.
we dropped a human from this height 60 times. Here's how they adapted. Yeah, probably not getting through ethics.
Yeah.
Cool. So just a little aside before we jump too heavily into bone stuff. Little question we've started asking on the RP podcast. What did you learn this week? Could be anything.
Oh, that's a broad question. What did I learn this week? Okay, I learned I'll keep it to three broad topics. So I learned about torso position and the change in loading on the knee and the hip. So as you lean your torso forward 10 degrees and you lean your torso back 15 degrees, that will change the loading quite significantly on the hip and the knee. So if you lean back, it's going to increase knee absorption by about 0.25. Whereas you lean forward, it's going to reduce it by about 0.35 and not so much of an effect on the ankle. That's the first thing. Second thing I learned about cadence and how taller people generally have a lower cadence. More experienced runners tend to have a higher cadence. And the jury's still out whether cadence is related to injury, which I'd love to hear your guys' thoughts on that. There's conflicting studies to say it's associated, but we can't really say that it is, and it's very hard to do those kind of studies. And yeah, the third thing was learning about the change in surfaces. Where we run on harder surfaces, the impact forces are actually lower compared to when we run on softer surfaces, which is a bit counterintuitive, but that's what I learned this week.
Yeah, super interesting. What do you think about the cadence, Steve?
Nice, yeah, interesting. Like as I said, like initially in my course, I was teaching like the opposite that you're talking there, but then like it is a little less elucidated these days. So yeah, I think
do you mean cadence, Steve?
Yeah, around that old 160 beats per minute or steps per minute.
Yeah, and it's not like I just
cut off zone.
Yeah, I just don't know the answer, because the studies I've looked at are saying like that they've taken people at the start of a running year and they've basically divided them into cadence over 160, as you said, and below 160. And the people who were below 160 were more likely to have anterior knee pain and medial tibial stress syndrome. But it's hard because obviously so many other factors. And they've done many studies like that to say there's association. But of course, they're always very clear to say this doesn't directly impact it. And it makes sense because the braking forces and the loading, but there's some other conflicting studies to say there's no association with it. So it's hard.
Yeah.
And then what was the second one with the harder surfaces and lower, was it lower peak forces?
Yeah, so the two types of studies that they do are one where you just run on a harder surface versus one where you just run on a softer surface. And they do studies where you go from harder to softer and then softer to harder, just to see what you anticipate. And they were finding that if you go from harder to softer, when you actually land on the softer surface, your impact forces are higher. But they think it's because you're anticipating that it's going to be softer, so you're trying to generate more stiffness. Well, that's what they hypothesize anyway. But of course, they're not able to then measure that over kilometers and kilometers. But I thought that was interesting, like your brain's your brain's anticipation of what the surface is going to be determines a little bit of like how stiff and how much force potentially you're going to generate. That makes sense.
That's cool because it's counterintuitive and counter to like the earlier research in that field. So that's awesome.
Yeah.
What about you guys? What did you guys learn?
Mate, I learned that I'm nowhere near as good at the specificity principle is the biggest issue in strength and conditioning and everything. It's the one that'll get you. So I rolled with a mate in jiu-jitsu, the Savo, and I've been doing a lot of fitness work lately, and 30-second, like just doing, alactic capacity work. I am not specifically trained to do that. I was nearly throwing up after 5 minutes, whereas, I've been doing heaps of 30K bike rides and going for jogs and, even doing sprints, but full body wrestling for, 20-second on, kind of 20-second off. Oh, that was not fun.
That's interesting.
So, yes, I was generally fit, but not specifically fit for that.
That's a pretty niche type of fitness. Like it's not often, unless you're playing like, I don't know, rugby or like maybe AFL, you would actually wrestle someone other than in a wrestling sport like jiu-jitsu, MMA stuff. So
yeah, and even my sprinting, because I do like sprints as well, where I do like, sprint for 5 seconds and kind of rest for, a minute or something, go again. But that didn't prep me. I was gassed.
Maybe you need more parkour, mate. Get down to the local park at Ready and
I wonder where along the specificity spectrum parkour sits for like between sprinting and jiu-jitsu.
Or use of arms. It's already closer for that reason, but yeah. Okay, what I learned this week.
Yes, I don't like the specificity principle anymore.
Fair enough. I had a bit of like a health scare earlier in the week. Not seriously, but I went to the toilet, took a piss, and it was just like fluoro red. And I was like, oh no, like
that's not good.
What's going on here? Like just pretty much I shat myself. And then realized that I'd eaten a lot of beetroot this week. And apparently beet urea is something that affects 18% of the population. And pretty much what it is your gut doesn't absorb any of the liquid aspect of the beetroot. So if you're like not fully roasted it and it's still like a bit juicy, your body can just like excrete it completely in your urine. And it led to like the most vibrant purpley red urination of all time. And it's scared me a lot. But apparently, 18% of people get it. And out of the 18% of people who get it, somewhere between 2/3 and 4/5 are iron deficient. But I don't think I'm iron deficient. I don't have any other symptoms. So I'm putting it down to beetroot at the moment, but watch this space.
Wow. Have you ever done any beetroot supplementation for your running there, Blake? Tried to increase because isn't that something to do with like erythropoietin? Doesn't it help with production of that?
Oh, I don't know what the mechanism is, but I definitely know that people talk about it, and there are supplements marketed to runners about it. But I haven't tried it myself. But if I do, I'll make sure to check my urine.
I think it's like EPO kind of thing.
Yeah, I think I'd just rather take EPO.
I saw something as well. There was a supplement, like a beetroot supplement, to do with like cognitive function and like potentially like aiding in like dementia patients and things like that. So I think you can pretty much, like we were talking about this off air before, you can pretty much market anything, can't you?
Yeah,
regardless of whether it's actually true or not.
For you to plug your product that you just made. Like, oh, by the way, I actually made this.
So rpe are now endorsing beetroot supplements.
Hold for a brief ad.
No,
or just beetroot farming as well. I very much endorse beetroot farming. Good for you.
Yeah, I could get around to farming.
Yeah, cool. So learned 3 very different things this week, but yeah, hopefully the listener takes away something of use. So with that in mind, let's dive into bone stress injury, stress fracture, that kind of thing. So I think we just start with the basics. So what is a bone stress injury? Kind of how does it happen? Do you want to run us through that, Blake?
Yeah, well, I guess there's always levels to these discussions of how in depth to go, but I think the easiest way to think about it, which you guys have mentioned before, is your bone needs some degree of homeostasis. You load it, it will get damaged, it will repair itself, and that process will continue to happen throughout your life. And it's always happening. Your bones are always remodeling, and it's really easy to think about it's this imbalance between remodeling and damage, and that's why they don't happen instantly, but they happen over time. So it's really a loss of homeostasis of bone remodeling versus bone damage.
Cool. We had the analogy a couple of weeks back of have you seen the rock, paper, scissors tournament simulator thing?
No, I haven't.
Where there's like scissors on one side, rock on the other side, and then paper, and they all kind of just match. And then eventually like paper will look like it's winning, and then all of a sudden scissors looks like it's winning, and then rock looks like it's winning. So we just have to kind of make sure that this process doesn't bias one direction too far. And if it does, hopefully it's like the bone building side of it rather than the degradation or like osteoclast side of it type thing.
Yeah.
So,
I like that one. I like the
do you see it like kind of a new way I've been kind of not reconceptualizing because it's been around forever, but like I think people very much think of the SRA cycle for things as being, and we've mentioned multiple times in our podcast now, of it being a static kind of cycle, but it's not, right. It's always this like influx. So you're always slightly stressing, slightly recovering, which means that it just leads itself to a continual model, right? Because things are like they're always in that flux, as you were talking about with that rock, paper, scissors analogy there, Connor, where sometimes you're loading, sometimes you're stressed.
Not ideal for a podcast, having someone stop you from speaking.
Yeah, don't talk, Steve. You got to stop talking. Mia's focusing on Coco Melon, is it?
Yeah, I think we were chatting offline about the analogy of, if you fill your car up with fuel, you have a full tank of gas, and you're going to drive, 8 hours, you're probably going to be able to drive that 8 hours without running out of fuel. And let's say for a bone stress injury or your bones remodeling, you're always driving or your bones are always remodeling, and you always need to make sure that you've got this homeostasis, that you've got enough fuel in the tank and it's continuing to change and just kind of have that buffer zone between it and happening. But there's lots of different ways to think about it. It just makes so much sense when that they're always remodeling and they're always getting damaged. You just have to keep homeostasis of that, and that's the easiest way to think about it. And it's an imbalance when that happens is when a bone stress injury is more likely to happen.
Mm-hmm. So on this note, what kind of things should we be looking out for that will kind of affect that homeostasis in like a negative way?
Oh, that's a really good question. And that's like the second layer. So the base layer is homeostasis, bones get damaged, and then they remodel. I got an interesting fact, a little one-liner, which is always good on podcasts, that they think that you would roughly replace your whole skeleton every 10 years. So it's a good idea to know that the bone that you've got now in 10 years, it's probably going to be new bone. But the things that can affect it, and there's just so many, and there's all these different categories of, certainly, even if you just look at load, purely just load, and that's usually the bigger contributing factors, even just the different types of load. So if you're a runner and you're just slowly running pretty easy and you're running 50 kilometers a week, your risk of injury might be roughly 1-to-1 if you increase that load at a pretty stable intensity. But if you increase it and add intensity and run quicker, that is a significantly amount of force through the bone. So your bone is going to be stressed more, and you may be more likely to suffer a bone stress injury. So things like load, obviously, the type of load, the frequency of load, which you guys have discussed really well. And then secondly, there's all these medical things as well. So, steroid use, there's medications. Some people genetically just don't have big bones. Some people just have smaller bones. So there's lots of things that can really affect their health, and also lots of things that can affect the remodeling rate. So we know that postmenopausal women, hormones can have a huge effect on how quickly the bone can remodel. And that's why a lot of bone stress injury studies are done in postmenopausal women, because they're at higher risk of things like osteopenia and hip fractures. So we need to certainly address the load and be aware of the load, but also understand all these other systemic factors that can affect this homeostasis. And we see that in like every tissue in the body.
I think a good thing to go into there, which I know is on our kind of run sheet, is we talk load. We've talked load a couple of times. You want to kind of elaborate into what load is for a bone there for a little?
Well, the way to think about it is, previously we thought it was impact, and it kind of makes sense. You load the bone, actually you're going to have some bending forcing through there, but the recent studies are showing that the impact forces can be pretty low, yet bone loads can be pretty high. And we seem to think now it's the muscles that are contracting and pulling and bending the bone, and it makes sense, especially in the tibia. The tibia is just the easiest one to think about. If you've got a really straight, long stick, and almost like a bow and arrow, and I'll explain this to patients as well, and you've got a bit of string that comes around the stick, that's like your calf muscle and Achilles tendon. If you pull on that, it's going to pull the stick and bend the stick. And that's basically how your bone will be loaded. And that's happening all over the body. It's just the tibia is the easiest to think about. So muscle forces are the big contributing factor. And we think it's around 80%. And then the rest is things like impact and axial load and gravity and all that kind of thing. So now that we know that, it's like, sweet, to load bone and get bone stronger, we just need to load the muscles. So it's just more evidence that heavy resistance training is so good for us.
In saying that, do you think that it would be possible to, like, if you give yourself like a humeral bone stress injury through like doing a heap of push-ups or something, because it needs, like, to be able to bend the bone enough biomechanically, physically, it needs a anchor point. So bicep curls are kind of out, because you're going to get a little bit of bending, but because it's also moving through space, made a huge bend on it, but we don't see enough humerus.
I know. I did say, I lost you a little bit, but you said we don't see the humorous ones. I've got a study in the course we're doing tomorrow, where it was the first study I ever read on like load and bone, where they looked at the radius and the ulna in baseball throwers, and like they just showed the cortical thickness. It was something like 67% thicker, and you see the images and they're huge. So it's like, yes, the muscle forces contribute, but it seems to be load over time, frequency are all the kind of general bone principles, but load plays such a big role.
Definitely. That's why you see like tennis players and throwers, they'll have like, even though it's not technically impact, their humerus size is like enormous on their dominant arm compared to the non-dominant arm. And they're not like, being a tennis player, we're not spending all our time doing impact. So it does show you the impact that like large muscle torque has on the size of bone. So yeah, cool. In terms of going through like different types of bone, we do have a couple of different types of bone. So we've got the kind of your cortical bone and your spongy bone type stuff. Did they respond differently, or are they still like, obviously your cortical bone has a little bit more capacity to bend, but things like your like sacrum and SIJ and things like that, do they respond like similarly do they respond the same to forces, or can we expect like different kind of presentations or different types of activities to lead to different kind of stress injuries depending on the type of bone?
Yeah, I mean, the further away you get from the foot and the ankle, I guess that the higher percentage generally you see of more trabecular to cortical bone. I like to think of cortical bone like my dad, he's an old builder, just tough guy, builder, loves to have a beer, loves to watch the footy. He's just, thick and tough. Whereas I like to think of trabecular bone as my mum, like warm, just like blood, a little bit soft and changes very quickly sometimes with her mood and how much she loves me. So that's what we think of trabecular bone. It seems to be a bit quicker and how it changes, whereas cortical bone, not so much. So when we see bones that have different percentages, like like say in the hip versus the metatarsal, it definitely does change a little bit of the loading principles and also the time frames and recovery. And we see that in the research too, whether or not it's purely addressed to the differences in percentage of cortical or trabecular, but we see that different bone stress injuries take longer, and that's in part, the percentage of cortical and trabecular. It's in part because of the blood flow. It's in part because of the biomechanical loads placed upon it. But I definitely do think it does play into time frames and what load we're going to put upon them, and I guess how quickly we might progress someone through the loading cycle. Sorry, through their rehab.
Yep. Okay. So with that in mind, if we're thinking like cortical bone is going to be a little bit more resilient to the kind of increases in stress, and the bones that have more kind of spongy type like makeup or a bigger percentage of spongy bone, they're going to respond a little bit more quickly to stress. So that might give you a little bit more insight into if someone comes in with a presentation and they've been, say they're a runner or something like that, if they've been building up slowly versus if they've been building up quickly, you can expect to see like symptoms pop up in different bony tissues. So yeah.
And the systemic health can impact, I think, at a high likelihood, although there haven't been that many studies on this, but from what we understand about the differences in cortical and trabecular, we could say that the bones that have a higher percentage of trabecular bone are going to be more likely to be affected by things that can affect our systemic health. So as an example, for RED-S, and if I'm not eating enough and my energy availability is low, I may be more likely to suffer a bone stress injury in a bone that's got a higher percentage of trabecular bone, because trabecular bone is more metabolically active. It can be more affected by systemic health quicker. So that is going to play into that. So that might be a potential risk factor and reason why we might see that. So even some of the other factors outside of that are going to have influence.
Yeah.
So that's why, the antennas are up when someone comes in and they have a bone stress injury in a particular area. We need to be questioning what other factors could contribute to this. And straight away, purely just from the location and also from the, I guess, the side and the bone, but we'll probably talk about that a little bit later, but purely from the location, your antennas can be up about potential contributing factors. Now, this isn't to say that everybody that comes in with a proximal bone stress injury has RED-S or has low energy availability, but it may be something more to consider versus if they come in and they have a third diaphysis metatarsal bone stress injury.
Sure.
Yeah, and that's, you're kind of describing there the differences of kind of that more insufficiency type fracture versus the fatigue type fracture, the more biomechanical versus the more kind of systemic there, aren't you? And which do you kind of see more often then would be a good one just in your personal experience with, because you work with a lot of runners, don't you?
Yeah, I tend to see more of the biomechanical ones. So I've got my goal as a sports podiatrist. I've diagnosed one femoral bone stress injury where someone actually come to see me first in big toe pain, and they were telling me how bad their hip was. And just imagine a podiatrist. I'm up here going, if someone's come to see me for their foot, I'm going, let's just focus on your hip a little bit more. It ended up being a bone stress. As a podiatrist, I only want to see an ACL, and then I'll be happy. I've seen everything in the lower limb, but I don't think I'm ever going to see an acute ACL coming to my clinic. But I definitely see more of those biomechanical failure ones where it is more related to load, but people can still have these other systemic things going on, and it's still worth addressing. So I asked everyone in the clinic that comes to see me that has I'm suspecting a bone stress injury. I asked them, do you have a regular menstrual cycle? Have you had a regular menstrual cycle in the last 12 months? Because that's a really important thing when it comes to hormone and bone health. And then for males, I ask around libido and morning erections, which seems very odd, I know, but it can be one of the small things that we can ask to figure out if someone might be in LAA. And I talk about that so much only because all the loading stuff, it's almost irrelevant if somebody doesn't have the energy availability. And we see this in the research as well, where if you're loading your bone and you don't have enough energy, your risk of a bone stress injury is significantly higher compared to healthy controls. And the stuff that you're doing to increase your bone mineral density actually isn't really working because it's being offset that you don't have enough energy to replace that bone. So I know we're not going to talk about it much, but it's just so important to address in people. Otherwise, they're just going to have another one, or they're just not going to be able to do any of the stuff that you're recommending.
Do you ever also like kind of audit, say, training load in a way of like your met minutes or any of that type of stuff? Because obviously there's research around like certain amount of met minutes being kind of healthy, and then certain amount being kind of top level of stuff, and then over that actually almost can be detrimental to kind of health because it's just the recovery burden is too much. And I know marathon runners, just from experience, as you're getting further into training, you're quite often getting up into those more burdensome minutes.
Yeah. I cannot for the life of me, and I really apologize to both of you and all the listeners. I can't find the study, but there is a study where they've looked at the difference in bone loading between running 537 per 537 pace. I can't remember if it's minute kilometers per minute versus 437, and the impact on bone tibial loading is quite dramatic. So certainly minutes do matter, but really when it comes to bone, it just matters on the intensity, because you can run pretty well flat 6 minute a K and you are loading the bone, but it's not that high of a stress. But as soon as you start to increase the propulsive force and the intensity, it's when the bone load dramatically comes up. So if you add an hour to your week of training and it's pretty easy and it's not really a high stress for you in running 6 minutes a K, your risk doesn't increase that much. But if you add an hour of high intensity intervals, 20 by 400, 10 by K, running really quick, your risk of injury is going to go higher. Plus the intensity as well, because you're using more energy. So you're more likely to be in LEA. So there's all those other factors as well. So it really comes down to intensity for me. And then of course, the big one is just how much change is there and how quickly have you changed, because all the bone stress in your research boils down to just doing too much too soon. If your bone doesn't adapt, well, you're just not going to be able to tolerate it, and you're almost destined for an injury, whether it be bone stress or tendon or something else.
That kind of matches up with what you were saying before about cadence as well, how you learned that like the cadence, how we used to think it was like increased cadence was protective, or vice versa, whichever it was. If the forces or the intensity are changing significantly and the cadence is staying the same, then it may not matter what kind of cadence you're running with. If the increase in intensity is just way more than what you're used to, then yeah, the cadence, you can see why it may not be associated with like bony injury.
Yeah. It's such an easy thing. I mean, I always usually manipulate people's cadence after they have a BSI, because and this is why I love people that talk about resistance training, which obviously you guys fit into that category, but it's just the idea that we shouldn't be a resistance training. Oh, this is for any injury, but people with a bone stress injury can have reduced bone mineral density up to 9 months after an injury, and sometimes it never fully recovers. So even though someone gets back to pain-free, they should be doing some osteogenic exercises for at least 12 months, you could say. And that's why we would say that, because it's going to be reduced. And then otherwise you could say, well, let's try and manipulate your cadence and get you up around 165, 170, for the long term, to try and protect your tibia or your bones a little bit, or your femur. But that's a small thing to do, but it's probably worthwhile. And honestly, most people just feel a little bit better with their cadence up that way anyway.
Cool. So you can that shows that you can manipulate kind of the cadence, the forces, all this kind of stuff to load different tissues, to offload, say, the tibia versus the femoral neck versus things like that. In terms of locations for like common bony stress injuries, or things that you would be kind of keeping an eye on, where could you expect to see like common sites in lower limb for like bony stress injuries? And maybe could we talk through like which are the risky ones as well?
Yeah, I mean, for me, it's obviously below knee, but easily the most common one is the tibia. That's the one that I see the most, the tibia and the metatarsals. And I wonder if that's because, plantar flexor forces have such a high correlation with load through those bone and your forces, and because they are so high. So don't know if that's true or not, but just a thought. They're the two most common ones that I see. And of course, the high risk ones, you just need to know what they are and what the low risk ones are, because your treatment changes so dramatically. I mean, we're not going to speak about all of them, but in the foot and the ankle, the navicular bone stress injuries, they are they are the absolute worst. Like I cannot explain how many people I have seen that have to have their navicular with a bone screw put in them because they don't heal, and either they get misdiagnosed, and the research says it's about 4 to 5 months on average until they are diagnosed, which is such a long time to have a bone stress injury in such a significant area. And then a lot of the research says that people are better off to have a screw put in there because it's actually going to heal quicker than what it would do in a conservative management. So there's just so many things that can go wrong. We don't really know the gold standard management for them. Offloading them is obviously hard. You have to be non-weight bearing for a period of time, like in a boot, in crutches. It's just they are such a hard injury to manage, and they're that one you've got to have if you have any suspicion at all, you have to be. In my opinion, it's a bit different because I work with sports doctors, but sending for an MRI, but even an MRI has a higher percentage in this particular area of actually missing a fracture. So in most cases, you actually may need to get a CT. So that's why it's always really good to get a sports doctor involved. If it's a bone stress, it's okay. It's not as aggressive with the offloading. But if it's an navicular stress fracture, it's just, alarm bells that are going off. This person needs to be completely offloaded just because the consequences are so high. Whereas like a third metatarsal one, you can have them back walking out of the boot in 4 weeks, just walking around, be guided by pain. So it is a real significant difference between these ones.
Mm-hmm. So essentially, the things that will kind of change something from low risk to high risk, is it just the healing ability, or is it the difficulty in offloading it? So what kind of things do you think make these particular bones high risk?
Yeah, so it's usually a combination of like the reduced blood flow is a big one, but even we're questioning this now. There was a recent paper that came out looking at cadaver models on the navicular bone stress, and I don't know if you guys got taught at uni, but I definitely did, and I was teaching this up until last year, where the main arteries come down in the foot, got dorsalis pedis, and you've got the other one that branches off, and the navicular kind of sits in this grey area where you don't have a lot of blood flow in through there. And that's why you guys get taught like the end spot. That's one you push onto.
Mm-hmm.
It's the avascular one. There's been some cadaver studies now to show that potentially there actually is blood flow in through there. So it might not be as avascular as what we thought, but blood flow is the big one. Secondly to that, it's just the biomechanics involved in those higher risk ones. So if you think of when you load your foot, the shape of the navicular is like a C shape. So as you load your foot, naturally you're going to get some deformation of your arch, which is completely normal. Please don't think that isn't normal. The arch will come down, you will pronate, and what will happen is your midfoot will essentially become a little bit stiffer, and you will bend the bone over in that kind of C shape. So as the force comes down, the bone will bend over, and on top you will have the margins of the stress reaction or fracture come apart. So that's why you get that higher amount of kind of tensile force in through there. So that's one of the tricky parts, is you've got an area or bone margins that are trying to come together, and you've got, every time you take a step, they're getting pulled apart. And that's what we see with the anterior tibia when you're walking forward. Plantar flexors are pulling the tibia open, and the margins are trying to heal. It's not very good for blood flow, and it's not able to come together. So they're usually the two big reasons of biomechanics and blood flow.
It sounds like bones better, like, and it would match the research here, but it seems like bones better can like taking compressive force rather than the tensile force.
Yeah.
And that's why you see like the nastier stress reactions or the stress fractures being like on the convex side of the bone as it bends. So like the navicular, the anterior tibia, and then the other one's like the superior aspect of the femoral neck.
Yeah.
So
yeah, they're pain.
I've seen you talk on this before, and I'd like to just have it on here. It'd be cool. About the continuum and the up for debate about say your most common one that you see in your tibial kind of bone stress injury, and like your medial tibial stress syndromes, and kind of do you see that as a continuum through? Is that how it's happening, or are they kind of separate pathologies, or kind of what do you see is happening there? And what's I just know that you've talked on it before, so I'd like to hear you elaborate on here.
Yeah, it's a bloody tough topic, and I ask this question to everybody that I meet. We went to a bone stress injury night here in Newcastle with the Ripon event, and we had a sports doctor, nutrition, physio, and a radiologist present on it, and pop my hand up at the end to ask everyone the question: do you think MTSS is on the continuum? Do you think it's a bone stress injury? And we actually had Greg Lovett as well, who's a sports doctor down in Adelaide, who's done a lot of stuff around BSIs. But it is a tricky one because, as we understand it, MTSS seems to be some irritation or some sensitivity to the periosteum, which is the coating that lines the bone. And the ratio of like peripheral nerves from the tibia to the periosteum is like 250 to 1. So that's why it gets so sensitive and sore, and people can have this really, really sharp pain. And it makes sense. The deep plantar flexors run just over the area. There are heaps of cadaver studies to show that the muscles cross where people get pain, and you get some kind of, I want to say rubbing because it's easier to think about, but you get almost like an enthesis irritation, or like you see in the insertional Achilles, like an enthesopathy across the periosteum. But when we look at what current research has been done, we really need to work out which is which, because a lot of the time are we going to expose someone or going to protect someone. So if a runner comes in with MTSS and it's like, oh, this is just an enthesopathy, that's okay. You can actually just run to symptoms, and you don't need to be too worried about this progressing or getting worse, and we just manage the load. Whereas if it's like a bone stress injury, we don't want to keep loading them because they're very likely just to end up, that the bone's already fatigued, they're very likely to end up with a BSI and have even more time off. So we looked at this one paper, my partner and I speak about a lot on the podcast, where they've taken people that have MTSS, clinically diagnosed by a physical therapist. This is over in the States, and there was only like 20 people. We did a social media post on it, and they followed them over time to see if they kept running and training, would they go on to develop a bone stress injury? And over 1 year, nobody went on to develop a bone stress injury, although they kept their training load at a relatively stable level. So that might give us some indication that MTSS isn't on the bone stress injury continuum. But some of the other radiological imaging, as image people and MRI of people with MTSS, you can see edema in the bone. But then it's the question of like, well, any runner who's been running for a period of time, they're going to have some edema throughout their body anyway. But again, they didn't do any follow-up. They just imaged them just to see. They didn't say, oh, did you go on to develop a bone stress injury, or classify the amount of edema, which would have been really, really cool. So currently, as it stands, I don't think it's on the continuum, and I think we can get a pretty good idea from their clinical history and a pretty good idea from our assessment. So the standard one is I've lost the statistic, but it's like 50 or 70% sensitive if you have pain less than 5 centimeters and pain with hopping, that you have a tibial bone stress injury, or you may have a tibial bone stress injury, versus if it's more than 5 centimeters of diffuse pain and they don't have as much pain with hopping and it warms up, then it's more likely to be MTSS. But that classic warm up, they don't have night pain, usually it's bilateral, it's diffuse, and when they hop, they don't point to one area. Like when someone's got a tibial BSI or some kind of BSI, they do a movement and they put some load to it and they really point to that area. But yeah, I don't think it's on the continuum. And I've got to admit, I've made mistakes before when I've loaded someone too aggressively with MTSS. They haven't gone on to develop a bone stress injury, but they've ended just flaring up, and I've probably a low level stress reaction, and we ended up just taking a couple of weeks off anyway. So my clinical decision now is, when somebody comes in, whether it's a MTSS or BSI, if I classify as BSI, I follow the normal protocols. If I classify them at MTSS, I then further classify them into, am I going to expose this person or protect this person? And I just use their clinical symptoms and their training history and their pain pattern to say that. So they're like, yep, I run 5Ks, it warms up in a couple of 100 meters, and the next day it's not too bad, a bit like a tendon, and I don't really get that much, I don't get any pain during the day, and I've got diffuse pain and I can hop. I'm like, great, we can probably expose you a little bit, or kind of keep you where you are and just change a couple of things. Whereas if they're like, yep, it's getting worse, the pain is taking longer to warm up, I've got a low level of pain, and I'm getting a little bit of pain during the day. I don't have any night pain. I don't have that much pain with hopping, but I'm aware of it. Well, I'm like, we probably need to cut you back, and we'll just have a couple of weeks off. So that's the long, I was going to say the short way, but that's a long way to answer that question.
No, that's awesome, mate. There's a couple little jump off points I was actually wanting to go from that. I think I'll go, one of the earlier points you came up with was the like level of edema. And like, obviously, that's going to be our bone, like that stress recovery adaptation response, like the inflammatory immune mediated response is the recovery response, right? That's how it's stress and part of that in something like the lower back. So with like cricket, they've done like, they grade it, and if someone has a certain amount of edema on their scan as they go, well, then they actually start to manage that, like start to load manage that a lot more. Is there anything kind of in the lower limb stuff there with our runners to go, hey, that is a regular bit of edematous kind of tissue versus no, that's actually kind of now this is load management, like this?
Yeah, not that I'm aware of. I did do a post on this a while back, just generally looking at below knee edema in the athletic population, and it is quite significant. And they've done, studies, as we were talking about off air, where they've taken MRIs of people leading into marathons, after the marathon, and a lot of people do have some degree of edema throughout their lower limb, but it wasn't a correlation of they went on to develop a bone switch injury. So there isn't anything that I'm aware of where we might be able to classify it. I think we spoke about like the things that you can kind of say, like if you're thinking of like, oh, how much can I really push this person if they've got a bone switch injury? There is the idea of the moment of inertia, which is probably the only thing that we have that's really like, I guess, something you can objectively classify, although that's pretty difficult as well, where if you imagine you have a cylinder and that's your bone, if you were to put a line directly through the middle, the distance from that line to the end of the bone, or the amount of mass in there, if there's more, there's a really good chance that they're going to have a stronger bone, or a bone that's more resilient to force loading. So that's probably the only thing that we can like kind of objectively say. And even that, like no one's going to be able to measure that clinically. You're not going to send people off for scans of that. So there isn't anything we can classify yet, but it would be so cool. And like, as we've talked about, like putting our engineering hat on, it makes sense if we could potentially model the failure rate of bone. Like if we were to take maybe their clinical history, work out the size of their bone, work out the diameter, work out all these things. Are like, all right, if we take a piece of concrete, this is how many loading cycles it would take until the concrete breaks down, which they can do in engineering models. Like, I mean, it's hard because you've got a human being and you're doing that with bone, but it would be cool if we could kind of work that out. Like, imagine we could say, yep, you just need to run 98 kilometers. That's your threshold with this much intensity. And anything over that, your bone's going to be more likely to break down. Like, that would be really cool, but there's nothing yet. And there's nothing with the edema either that I'm aware of.
And then the interesting thing as well with the talk about the kilometers and the intensity, the other one that we've talked about earlier in the bone loading series is variation, right? Because, your marathon runners are more like, well, maybe not 100%. And you'll let me know this, actually. Running isn't my favorite population. So, but like trail runners, with getting that variation of it, it's a different load. They get that kind of the forces coming from all different directions. So maybe that's a more sustainable kind of training modality from time to time than kind of just hitting the pavement on a flat surface. So those things, like you got the volume, the intensity, but also the kind of surface variation and the directional vectors that the force is actually coming at.
Yeah. There's an awesome paper called the 3 rules for bone adaptation, and the third rule in there is bones get bored. So if you load them, the same way every time, they almost become adapted to that. So variability is really good for bones. So that's why when we get people doing their bone loading programs, like, hey, just jump around the room, hop, jump, have your kids jump around with your kids, skip rope, and have someone push you. Like, just do anything that's different to you just hopping on the spot. So trail running fits that really well. The only thing I'll say about trail running is for the below knee stuff, and I guess kind of above knee as well, is if you do a lot of elevation, you like significantly increase your plantar flexor force when you're running uphill, because obviously you land on your forefoot and then you'll contract to be able to not lose any force and push up. So if you kind of control the elevation, it can be such a good, just different variation to do. Whereas if you do a lot of elevation, it's like, oh shit, well, you're really loading your plantar flexor, which means your tibia and your metatarsals are going to get quite a bit of load through them.
And the last one with variation there I'd like to go into is like cueing stuff. And so like, talking about different ways to run, like telling someone run quick, telling someone to run heavy, run soft, or, run to certain beat, like all that type of stuff. Like what's your, are you using that very often in clinic? And what are you kind of, what's your clinical reasoning kind of thought processes there?
Yeah. I'm so happy you brought this up because, as I mentioned, we're doing a course tomorrow down in Sydney on runners. I'm speaking about biomechanics, and I love this really cool study where they looked at they put a tibial accelerometer on people's tibia to basically get an idea of tibial loads and trying to hypothesize what the tibial bending forces were, which is difficult. But anyway, they looked at giving people 3 different cues verbally and seeing what would happen if the goal was the same. So they're trying to get people to basically shorten their step. So they said one group, you're going to reduce your stride length. One group, you're going to run softer. And then one group, you're going to try and land closer to your center of mass. And funnily enough, people significantly increase their cadence when they were told to run softer and bring their foot closer to their center of mass. But there wasn't that much of a difference when you tell someone to reduce their step rate. So it was really interesting to see that like even running cues can matter how someone takes that on. So just be aware that if you're seeing runners, you might have to have a couple of different cues or ways that you say it in your back pocket. And it makes sense because in the S&C world, different cues can mean different things for everyone. Like I know for me, when I squat, the cue of trying to spread the floor really just makes so much sense to me. Whereas my partner Kelly has given me other cues. And I'm like, these don't make any sense to me. But yeah, so different cues can mean different things. So a lot of the time, the big one is cadence, just because you're going to not reduce the overall force, but you are going to reduce the peak magnitude of force. And that's going to be a bit better for bone loading. But definitely cadence is such an easy one to do. And a lot of people kind of expect that in a way because that's the stuff they read online. That's what they talked about runners about. So cadence is a big one, and that's the one I'll change the most. And then secondly to that, you kind of may play around with hip position, but to be honest, I usually just stick with cadence if it needs to be changed. And if someone's overstriding, because it's the easiest, it's the biggest bang for buck. Very rarely will I change someone's foot strike pattern, because that can have a huge change. Like if you go from landing on your heel to the forefoot, it can be up to a 35% difference in loading on the knee, which is obviously dramatic. And that's awesome if you've got knee pain, but you need to move the load somewhere else and you're going to be moving it down to your foot. So we need to be careful with these changes if we're making really big changes. But for most of the time, it's cadence, it's hip position, and just trying to get them running in a bit better of at a pelvic position, and sometimes foot strike pattern. And usually it's from more, I think you have a continuum of heel strike and forefoot strike. I'll usually try and bring them back a little bit. So they might not land as hard on their heel. They might be a little bit in front. And that usually changes when I change cadence anyway.
There was one recent study that really, it changed challenged me a little bit on things. It was the one talking about they got them running at the same kind of cadence and same speed, but they got different cues. And like the quiet cue, it decreased the initial kind of braking ground reaction impulse, but actually increased the internal moment, your internal muscle impulse. So it was really interesting because it's going cool. Like you were having to run quiet. You were actually you were hitting the ground less hard, but to do that, you were doing that by controlling with the plantar flexors at a greater rate. So I'll have to find the paper, but that was it was a really, really interesting. I was like, oh shit. So what is actually happening here?
Do you think that the net stimulus on the bone would be the same because of that though? Or do you think it would actually be more?
It was a joint moment, wasn't it? The joint moment increased.
I would have to go back and look at the paper again. So I can't remember off the top of my head. Sorry.
Yeah, that's cool. The cueing stuff's so interesting.
Right.
And it's so like the research on, I'm just going to give a shout out to every running injury researcher, because it's just, you can find anything you want. Like you can literally just type in whatever and type in PubMed after it. I mean, I'm biased because I've got access through because working and teaching at the university, I can get to papers, but they've done so much research. And I think it's because it's so easy to do. Like if you're trying to recruit people for a bone stress injury study and follow them over time and see how you can change their bone mineral density or their size of their bone, it's really hard. But if you get 12 people on a treadmill, you can say and do whatever you want and just measure the change and then write a paper on it. And you can do that in healthy versus non-healthy people, and it's pretty interesting. So there's lots out there for people that want to delve into it more. But yeah, it's really, cadence is like the big one. It's just so easy to change, and it makes sense for a lot of people as well.
Thank you for tuning in to part 1 of our bone stress injury podcast with Blake Withers. We have broken our conversation into 2 parts to keep it nice and digestible. So if you wish to go and listen to part 2, that will be released at the same time as part 1. Thanks again for listening, and we'll see you next time.